This talk is about cranial nerve examination. This is the second session about cranial nerve examination. During this session, we will talk about cranial nerves 5 and 7 to 12. These are the class objectives. You do not need to read them. We will use them to chart our talk. After extraocular cranial nerve examination, we check the trigeminal nerve. We start with sensory examination, usually testing soft touch, pinprick, equivalent to pain, temperature assessed by alternating tubes with warm and cold water, and asking the patient which one is it, and lastly, vibration sense. We will first assess touch, pinprick, and temperature. For the purpose of our talk, I will only use soft touch for sensory testing of these three modalities. Soft touch is tested by asking the patient to tell you where they perceive being touched, or simply by asking the patient to say yes the moment they feel they are being touched. We start by touching the forehead. We do the same operation in the skin just lateral to the eye and at the same level but halfway between the eye and the ear. We also do the same below the nose and at the chin on the left side. Then we do all the same on the opposite side, that is on the right side. The purpose of the multiple site testing is mapping the sensory territory of the trigeminal nerve to be able to distinguish nuclear distribution from a nerve branch or dermatomal distribution. When normal, the patient will answer yes to all. When abnormal, the patient will say yes to some and not to others, or not to all of them on one side, or both sides. I will describe two patterns of deficit that suggest different sites of pathology. In the first pattern, all sensory testing is normal except above the lip. Then the area is mapped and we find a deficit in the shaded area. This pattern is suggestive of brain stem pathology. In the second pattern, abnormal sensation is present at and just below the lower lip, between the ear and the eye, and in the lateral forehead. This distribution corresponds to involvement of the mandibular branch of the trigeminal nerve. Why? Here you can see two facial maps, one corresponding to the nuclear arrangement, the second one to the dermatomal arrangement. Abnormal sensation in the indicated area by the word no, with normal sensation elsewhere, suggests a nuclear lesion. This pattern should prompt a more extensive trigeminal sensory testing and to consider the possibility of a brainstem lesion. On the other hand, abnormal sensation in V3 with normal sensation elsewhere, that is sensory abnormalities restricted to the third branch of the trigeminal nerve, suggests a peripheral lesion. Why is it so? Because the anatomical differences between the spinal nucleus and the nerve branches of the trigeminal nerve. Here you can see the nuclear arrangement map. I have now introduced the spinal nucleus of the trigeminal nerve. Notice the color arrangement corresponding to the facial zones. I am now introducing the sensory components of the trigeminal nerve. Notice that all branches have different colors. The structure indicated is the semilunar ganglion. and I have now introduced the facial dermatome map using the same colors as the branches. Depicted in aqua in this frame, you can see the central axons of the neurons in the semilunar ganglion bringing sensory information to the trigeminal spinal nerve nucleus. Those for V1 end up in all three areas of the trigeminal nucleus. So do the ones for V2 and V3. Now notice the interrupted lines just added, indicating the boundaries of the nuclear territories superimposed on the representation of the trigeminal nerve branch territories. Hence, nuclear lesion usually affects all three trigeminal nerve territories, where branch lesions are restricted to the branch affected. At this point, I would like to make 3 additional comments regarding sensory testing and cranial nerve 5. The first one is a case presentation that was published in 2011. The case report is that of a 42-year-old woman presented with acute onset of facial numbness. Physical examination revealed graded loss of pain and temperature over the left half of the face, as you can see in this photograph, with maximal deficit peripherally, indicated by the red arrow, and normal sensation around the lips and lower nose, as indicated by the green arrow. You can see in this new frame a parasagittal MRI showing the extent of the lesion. The lesion is in the region of the spinal nucleus of cranial nerve 5, extending to C2. And in the transverse view, you can see the lesion on the left side corresponding to the area occupied by the spinal nucleus of the trigeminal nerve. The second comment is a controversy. This is the internal architecture of the spinal nucleus of cranial nerve 5 we have so far explained. Notice the color of the pars oralis corresponding with the central area of the face, the pars interpolaris corresponding to the middle region of the face, and the pars caudalis corresponding to the most lateral area of the face. Hence, in this version, all the spinal nucleus of cranial nerve 5 is involved in sensing pain and temperature. Now look at this other representation. In it, you can see represented that only the pars caudalis, here enlarged and numbered, is involved in pain and temperature perception of the face. The third comment is about the blink reflex. The blink reflex is seldom tested in clinical setting other than in those occasions that the deficit needs confirmation and there is poor patient cooperation, or in cases of coma. The efferent arm of this reflex is mediated by the ophthalmic branch of cranial nerve 5. The body of these neurons reside in the semilunar ganglion. Their proximal axon make contact with neurons in the nucleus of the spinal tract of cranial nerve 5. The axon of the neurons in this nucleus reach the blinking center in the reticular formation. The axons of these cells in the reticular formation reach both facial nerve motor nuclei. They send signals to produce bilateral contraction of the orbicularis oculi and eye closure. Abnormalities involving the right or left ophthalmic branch of the trigeminal nerve results in lack of eyelid closure in both eyes. The fourth modality of sensory testing is vibration. Most neurologists I know use a 128 turning fork for this purpose. We will talk more about the choice of turning fork during the sensory examination talk. How is this test done? And what is normal? Facial vibration sense is studied by placing the stem of the vibrating turning fork at the angle of the jaw and asking if it is felt. The patient should feel it. Then move to the chin and do the same, ask the same question, and the patient again normally will feel it. Abnormalities in vibration sense in the face are seldom encountered. Sensing vibration in one side of the jaw and absent in the other may suggest a pontine lesion in the main nucleus of the trigeminal nerve. The fifth cranial nerve, the trigeminal nerve, also has a motor component. Motor examination of the trigeminal nerve should include all the elements of motor examination for any muscle, starting with observation, that is looking for asymmetry in the jaw. Tone is assessed by feeling the muscles, and power. Power is tested by putting your hand below the jaw and asking the patient to open his mouth as such. In case of normal motor function, mouth opening power is good, and there will be no jaw deviation. The muscle that opens the mouth is the lateral pterygoid. If abnormal, let's say in the presence of a right trigeminal lesion, represented here by the red trigeminal nerve, when you put your hand below the jaw and ask the patient to open his mouth, the jaw deviates to the right. That is, to the same side of the trigeminal nerve lesion. And mouth opening will be weak. After power is examined, we check one reflex. The jaw reflex is tested by asking the patient to open his mouth slightly, and when he does, placing your hand softly with your thumb in the jaw, as shown in this figure, or you can also do it by placing the index finger, and then you tap on the thumb or the finger, depending which one you use to put in the jaw. At this time, you should feel a minimal jolt as a reaction of contraction of the masseter muscles. The primary muscles tested are those that close the mouth: the masseters, temporalis, and medial pterygoid. If abnormal, the abnormality could be in the lower motor neuron, let's say right trigeminal motor lesion. The jaw jerk is decreased. But on the other hand, if the lesion is in the upper motor neuron, the jaw jerk will be increased. After the trigeminal nerve, we evaluate the facial nerve. How do we evaluate this nerve? And what is normal? To test this nerve, we do 5 things. 1. Make the patient smile or cry, preferably smile. This represents a quiet face. Smile will bring about actively closing the eyes and separating the angles of the mouth. Both actions should be symmetrical. Alternatively, we can ask the patient to crease his forehead, show his teeth, close his eyes while we try opening them, and blow his cheek as we press on them. The blink reflex was already discussed when talking about cranial nerve 5. The blink reflex can also be triggered by sound, and by shining a bright light to the patient's eyes. In all these cases, eye closure should be bilateral. The second thing we'll make them do is to taste. The anterior two-thirds of the tongue taste sensation is perceived by the seventh nerve. We instruct the patient to taste while keeping the tongue out. We try sweet and sour, which they should be able to identify. The third thing we make them do is to make them say me, me, which a normal patient should say clearly. A good me, and unlikely seventh nerve deficit to be. Notice the arrow in the M. The fourth thing we would like patients to do is to listen with each ear. Usually what I do for this test is to rub my fingers close to the patient's ear and ask which one is louder. The patient should say that both are the same. The fifth way of testing the facial nerve consists of testing the parasympathetic function. This is seldom done. Parasympathetic seventh nerve testing is done by measuring the tear output from each eye. This is called the Schirmer test. The lacrimal reflex can be stimulated by stimulation of the nasal mucosa. If there is seventh nerve abnormality, we could see a lower motor neuron lesion involving the motor nucleus of the facial nerve, intrapontine fibers, or nerve itself. Lower motor nerve lesions involve the upper and lower quadrant of the face on the same side. I will show you two examples of nerve injury. Look at this newborn, all looks fine. Now, when he cries, you can see the asymmetry involving the upper and lower face. The right side is normal, the left is abnormal. This is the second patient. Again, the normal side is the right, and the abnormal side is the left. An abnormal blink reflex due to lower motor cranial nerve 7 lesion reveal lack of eye closure in the affected side. Here you can see indicated a lesion in the right facial nerve. Stimulation of the left cranial nerve 5 produces left eye blinking but not blinking of the right eye. Other symptoms of lower motor neuron pathology involving the seventh nerve are lack of taste in the anterior two-thirds of the tongue on the side of the affected nerve, hearing sounds louder on the side of the affected nerve, and not being able to say me clearly. This last symptom is also present in upper motor neuron lesions, since lip muscles are affected in both. In this frame, you can see decreased tearing of the right eye. Right facial nerve damage prior to the geniculate ganglion decreases or halts tearing of the affected side. The second type of facial nerve lesion involves the upper motor neuron, and it is expressed as weakness in the lower quadrant of the face. In this situation, frontal creases are normal, nasolabial fold is involved and droops, and so does the corner of the mouth. This pattern of facial weakness occurs with cerebral or midbrain involvement of the fibers going to the seventh nerve motor nucleus. After the facial nerve, we check the vestibulocochlear nerve. The vestibular and cochlear nerves, although anatomically together, are functionally quite different. They are studied separately. The auditory system is tested by finger rubbing and soft voice, and by performing Weber and Rini testing. We will first talk about finger rubbing and soft voice detection. As in the past, we will talk about testing and normalcy simultaneously. The first thing I like to do is to rub my fingers close to the patient's ear. Normally, the patient should hear it. The same goes for soft sounds. They should be able to hear it well. If abnormal, rubbing the fingers cannot be heard, and soft voice neither. After these procedures, we do Weber and Rini testing. These tests are done using a turning fork. The turning fork most often used is a 512 turning fork. The first test done is the Weber test. Tap the prongs of the fork to make it vibrate. Place the stem in the up middle region of the forehead and ask if the patient hears it. Normally, the answer should be yes. Then ask if it is heard equally in both ears. Normally, the patient should say yes to this question also. After the Weber, we do the Rini test. The Rini test establishes the time relation between bone conduction and air conduction. Normally, sound conducted by air is heard for longer than sound conducted by bone. The Rini test has two steps. During the first step, we test bone conduction of sound. You bring the vibrating turning fork and place the stem in the mastoid and ask if it is being heard. The patient normally would say yes. Ask the patient then to tell you when he stops hearing it. Wait until he says, now. Then you move to the second step, which is to check air conduction. Air conduction should last longer, as was previously mentioned. So immediately after the patient says, now, you remove the stem from the mastoid and bring it so the end of the prongs are close to the patient's ear, and ask the patient if he hears it. The patient normally would say yes. The left ear Rini test is thus normal if all these steps are taken and the patients answered appropriately. And then we do the same in the other side. In this case, in the right ear, and we should get the same results. What about if abnormal? Abnormal Weber and Rini test will yield 4 patterns of abnormalities. Neurosensory deficit in the right ear, conductive deficit in the right ear, neurosensory deficit in the left ear, or conductive deficit in the left ear. We will illustrate the first possibility, that is neurosensory deficit of the right ear with the left ear being normal. This possibility has 2 presentations. The first presentation is illustrated in this frame. Notice the red cross. It implies injury to the cochlea, the auditory nerve, or both. In this case, the Weber test results in hearing the sound on the left ear, but not on the right ear. Since the left ear is normal, the duration of the sound of the turning fork in the mastoid will be relatively long, and when the patient no longer hears it, air conduction of the vibrating turning fork will still be heard. On the other side, where no bone conduction was perceived, when using the turning fork in the forehead, no bone conduction will be appreciated when placing the turning fork on the mastoid, and no sound will be heard during air conduction testing. The second presentation is illustrated in this frame. Here the Weber is heard with both ears, but it is louder in the left ear than in the right ear. The left ear, since it is normal, has longer air than bone conduction. On the right ear, bone conduction is present, but only for a short time, and it ends quickly. And air conduction is also heard after bone conduction stops, also for a short time. Hence, the relation between bone and air conduction is kept. We will now illustrate the second possibility, conduction deficit in the right ear. In this frame, I am representing a patient with conductive hearing loss. I am representing it by a red cross in the external and middle ears. Patients with conductive hearing loss have good hearing discrimination in accordance with their degree of hearing deficit. Weber test will localize to the abnormal ear. Rhine test in the normal ear will reveal air conduction greater than bone conduction. In the abnormal ear, bone conduction will be normal, but once the sound is no longer heard and the turning fork removed from the mastoid and placed close to the ears indicated here, the patient will hear no sounds. This constellation of findings indicate that bone conduction is greater than air conduction. After auditory system evaluation, we check the vestibular system. We already mentioned the optokinetic reflex, the caloric testing, and now we are going to mention the Dix-Hallpike maneuver. This maneuver is performed with the patient in a sitting position, and from that position we turn the head of the patient to one side, as you can see in this frame. From sitting position, the patient lays down with the head lower than the body and tilted, as you can see in this frame. Then the same thing is done on the other side. The presence or absence of nystagmus should be noticed. Normally, there should be no nystagmus. If there is nystagmus, then notice type, direction, onset, whether immediate or delayed, and whether it is fatigable after multiple trials or it is not. Rotational nystagmus with fast component towards the ground that does not start immediately after reaching the head down position, that is delayed, and fatigable usually indicates a benign paroxysmal positional vertigo. Otherwise, consider the possibility of a central mediated nystagmus or other types of peripheral nystagmus. After cranial nerve 8, we check the glossopharyngeal nerve and the vagus nerve. How we test these nerves and normalcy will be discussed simultaneously. We test these nerves by asking the patient to open his or her mouth and say ah. Normalcy is established by elevation of the palate being symmetrical, which is confirmed by the midline position of the uvula. Then you ask the patient to cough. It should be strong. and you listen to the quality of speech. Voice should not be nasal. And ask the patient to say coo, 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 and see how this is pronounced. A good coo, coo, coo makes it unlikely for there to be a problem with the vagus nerve. And at times, if pathology involved this nerve is clinically suspected, we gag the patient by touching behind the pillars and observing the elevation of the soft palate, which should be symmetrical, and accompanied by tongue retraction. The last thing we do at times is to ask the patient to drink, making sure that the patient swallows well. If abnormal, saying ah may not be associated with elevation of the palate, or the palate may elevate asymmetrically, the uvula deviating to the normal side. Cough is weak, voice is nasal. Gag may not be present, and if present, will be asymmetrical, the uvula deviating to the normal side. And if we ask the patient to drink water, the water will come out through the nose, in addition to there being coughing. One question we must ask at this point is how to distinguish 9 from 10 deficit. It is easy. If the problem is in the glossopharyngeal nerve, we will find the following. When saying ah, the palate elevates and the uvula remains midline. The test is normal. 9 is not used for this test because the stimulus for the palate to go up is not triggered by sensory stimulation of the back of the throat. Thus, this test does not actually test cranial nerve 9. But the contraction of the palate muscles, which is mediated by the 10th, is good. If then we find no response to gag, since we already know that 10 is working, we can conclude that 9 is not. Then there is a glossopharyngeal deficit in this situation. If the problem is in the vagus nerve, we will find the following. The A does not produce or produces an asymmetrical palate elevation, indicating that there is a motor issue, which is confirmed by the absence of palatal elevation or asymmetrical palatal elevation and normal tongue retraction. Tongue retraction is the second component of the gag response, the first being palatal elevation. This constellation of findings indicates a vagus nerve lesion. Tongue retraction is accomplished by activation of cranial nerve 12 following cranial nerve 9 stimulation. After testing the 9th and the 10th cranial nerve, we test the accessory nerve. How is the accessory nerve tested? When testing the accessory nerve, it is best to test the sternocleidomastoid muscle, to which we will refer as to SCM, and the trapezius separately. This is so, at least in part, because of their peculiar anatomy. This diagram illustrates the cortical innervation of the right nucleus of cranial nerve 11. Notice that the right sternocleidomastoid is innervated by the right accessory nerve, whose bodies are in the right spinal cord nucleus of cranial nerve 11, and that this nucleus receives innervation for the sternocleidomastoid muscle from the ipsilateral cortex. Now, notice that the right trapezius as the right SCM is innervated by the right accessory nerve, whose bodies are in the right spinal cord nucleus of cranial nerve 11. But this nucleus receives innervation for the trapezius from the contralateral cortex. Hence, it is best to test them separately. SCM testing starts by assessing both SCM simultaneously by asking the patient to flex the neck forward. Then we test the left SCM. The left SCM can be tested by left lateral neck flexion or using right neck rotation. This is first done by the patient without physician assistance, and little later the same action should be done, but this time with the physician feeling the strength of the muscle. The right sternocleidomastoid can be tested by right lateral neck flexion or using left head rotation, as it was done for the left sternocleidomastoid muscle before. This is first done by the patient without physician assistance, and a little later the same action should be done now with physician resisting the movement. These maneuvers will be further detailed in the next few frames. It stems from the discussion above that 3 maneuvers help us evaluate the sternocleidomastoid muscle. The first maneuver is simple. You ask the patient to flex the neck forward, and with your hand try to straighten the neck as you judge the strength of the contraction. The second maneuver is neck rotation. It is done with the patient looking forward. You hold the mandibular bone on one side and instruct the patient to turn to the right side while elevating the chin. That is, to the side that you are holding with your hand. As you apply force in the opposite direction, you will notice a significant force going against your hand. And as you palpate the left SCM with your other hand, you will notice that it will tense up, a proof of its contraction. Then you should do the same on the opposite side. The third maneuver consists of lateral flexion of the neck. It is done with the patient looking forward and while holding the head by the right side as shown in this frame. You instruct the patient to try to touch his right shoulder with his right ear as you offer resistance against that movement. This way, you are testing the right sternocleidomastoid muscle. Then you do the same on the other side. An abnormal sternocleidomastoid muscle is detected by noticing limited range of motion or limited force. After testing the SCM, we go to the trapezius. Trapezius testing uses 2 maneuvers. The first and the classical maneuver is very simple. You stand behind the patient and ask the patient to shrug their shoulders. As the patient does so, you apply pressure down to see the force. This maneuver checks the trapezius as the patient tries to push his shoulders up. An abnormal trapezius in this maneuver is detected by noticing limited range of motion or limited force. The second maneuver consists of arm flexion at the shoulder. This figure illustrates the maneuver. The patient is trying to bring both arms up to the shoulder. Here, only one arm is being shown in this frame. As the patient attempts to bring the arms up, the examiner resists the thrust of both arms. I will use this patient to illustrate the use of shoulder flexion to evaluate the accessory nerve. This is an example of weak left trapezius. Notice that the left shoulder is lower than the right. This photograph was taken as the patient is attempting to abduct both arms while being resisted by the mother. The effort by the patient is being indicated by the arrows. This new photograph was taken while the patient was attempting to flex the arm at the shoulder. As you can see, as he attempts to raise his arms, the asymmetry is worse, indicating left trapezius weakness. After the accessory nerve, we check the hypoglossal nerve. How do we do it? And normalcy again will be looked at simultaneously. We test this nerve by observation. We ask the patient to open his or her mouth and let the tongue rest. We look for atrophy, asymmetry, and fasciculations. None should be present in a normal tongue. Then we ask the patient to stick the tongue out. The tongue should maintain the midline position. And we ask the patient to say la, la, la. With normal la, 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 it's unlikely for there to be a 12th nerve problem. What is abnormal? If the pronunciation of la, la, la is fumbled. Also, if we see atrophy or asymmetry, or if we see abnormal tongue position once the tongue is sticked out. I want to show you this case of hypoglossal involvement. As you can see here, with the tongue resting, there's only a slight volume asymmetry between the right and the left side of the tongue. But when the tongue goes forward, we see a significant asymmetry. The left side is normal, the right side is abnormal. The tongue, as it comes forwards, deviates towards the abnormal side. Thank you very much for your attention.